we should all have a talk after the workshop about chill and moving forward. Okay, great. Sounds great. Yes.
All right, everybody.
Everybody take a seat.
So everybody come sit down.
Great, good afternoon. I'm really happy to be here to celebrate this Pete, his anniversary. And I'm going to speak a little bit about my experience with the MedG group, the first couple of slides. Then I speak about my recent research, which I hope is of interest of this community. So I joined MedG in 1991. I'm originally from Europe, from Slovakia, which is just across the border from Hungary, you know, where Pete is from. And the year I joined...
In fact, you're from an old Hungarian city.
Yeah, there was called Upper Hungary at some point, a long time ago.
That's called Pete imperialism.
I don't speak Hungarian, though, some words. But anyway, so the year I joined, there were 4 students who came and joined MedG at the same time. Just listed the names, so Pete recognized them, right? Ron Botkin, Jai Balasubramanian, and Michael Frank, 2 were master students. They do very well. Ron is at Google. Jay is at the University of Pennsylvania. I think he's doing astronomy and physics. You know, and Michael Frank was PhD. He did reversible computing at the end, I think.
If I can interrupt you, so Vijay was a terrific student.
Yes.
And he came to me after he did his master's degree and said, well, I'm going to go to Princeton and study physics. And I said, well, good luck on Wall Street, because that's what happened to physicists. And then when he did get his PhD, he came to visit me especially to sort of stick it in my face that he had indeed gotten a faculty position at the University of Pennsylvania. So my prediction was as accurate as it usually is.
Actually, remember his master thesis because it was about how to control the number of states in hidden Markov models. It was actually nice work.
So what's Michael Frank doing now?
I think it was the University of Florida, Gainesville, at some point, but I lost track.
Trump University?
But he was doing reversible computing towards the end. He switched the fields. So anyways, Michael said before me that it was MedG at that time. It was an incredible group of students, and I recognize about half of the students on the picture he showed. So they overlap with me. And what I remember most is the discussions we had during MedG seminars, journal clubs, always arguing, you know, all opinions were, you know, floated. And the teams that we discussed at that time were probabilistic graphical models, that was the team, later Guardian Angel, and then web-based EHRs, right? There was other teams. I mean, we had the temporal abstractions and Zach and Ira Heinowitz were working on this. So it was very, very great discussions. I, you know, was amazed when I joined, and you know, it was excellent environment. I just expect that everybody experienced the same thing. I mean, given Pete's leadership. So in terms of research, this is what I worked on during my MedG years. This reflects ups and downs of my PhD study. I started to work on a project, closed loop ventilator control, where we tried to basically automatically control ventilators. There are about 4 buttons you can tune. And what we're trying to do is to come up with the optimal control that improves patient outcomes in terms of, you know, when they experience some diseases that require them to be put on ventilators. And the disease we studied was ARDS, or adult respiratory distress syndrome. So I remember this very well because it didn't turn out to be my thesis topic, but I gained lots of experience working on this project. And what was kind of interesting about that project, we didn't have the data we have today. Okay, and there were also not very good models about how to do and optimize the ventilator control and ventilator settings. I think we can do better these days. So, but the other thing that came out of that project, this was at Children's Hospital, this Jim Fuckler, Zach, and Peter, we were collecting the data from these ancient spacelab monitors at Children's Medical ICU, and we were able to get the data, pull the data about once per minute out of 15 bedside monitors. So this was early data collection that was about 93, 94. So this was kind of like down in terms of my PhD thesis, because I didn't finish this topic, but it was great experience that I built up and in my later research. And finally, what I worked on and finished as my thesis topic was decision-making in the presence of uncertainty. I worked on partially observable marker decision processes and approximation algorithms for those. And I also touched reinforcement learning, did some work, and I applied some of these models to optimization of management of ischemic heart disease. So having said that, it was very interested to work on this project under Peter's guidance. You know, he always lets you do what you want. You experience things, you fail, then you go up. He always had your back. So, you know, that was a great thing about it. Now I move and rewind forward. Unfortunately, it's nearly 20 years rewind. The time flies so quickly. So this is the present time. I'm professor at Computer Science Department, University of Pittsburgh. I'm also have multiple secondary appointments with medical school, Department of Biomedical Informatics, and also we have something called Intelligent Systems Program that looking at AI and applications of AI. In academics, I teach regularly AI and machine learning courses undergrad graduates. I already advise 11 PhD students as primary advisor. I have to finish 4 more next year. That's actually a large feat to accomplish. They're all graduating in 2020. I still do research in machine learning, AI, and biomedical informatics. So these are a couple of things that I'm looking at currently. There are other topics I worked on in the meantime. So I'm interested in models of time series data. And I'm looking at different ways of featureization and defining low-dimensional representation of multivariate time series. I was working also and still at some papers on temporal pattern mining. And mostly I'm interested in deploying these models in healthcare settings to model patient states. The other project that I'll speak a little bit more in detail is outlier detection, where we are trying to detect in electronic health records unusual patient management actions, and we use this to try to improve patient safety and detect medical errors or potential medical errors. The other projects that I actively work on currently is efficient annotation and acquisition of knowledge from human feedback. We look at different types of feedback aside from just labels that are assigned to instances. We look at auxiliary label feedback, group-based feedback, and so forth. And actually, very recently, I'm going back to reinforcement learning, and this is also in context of health. Let me speak a little bit about that second bullet, outlier detection and its application to patient safety, because it's my big baby project that I work on for more than 10 years now. So here is the motivation. So all of you know the patient safety has been in the center of attention of researchers in healthcare for some time now. It all started around year 2000 with very important NIH reports to various human. It basically laid down what is happening in terms of the healthcare and medical errors. And there were some estimates that try to assess how big the problem is in terms of the cost to the healthcare or the number of deaths. There were multiple studies after this 2000 report that just kept saying the medical error problem is more than we expected. So it's much larger than I thought at the beginning. And in 2015, 2016, there is an estimate in that the medical errors are the 3rd leading cause of death to patients that are hospitalized. So what this implies is that we need better solutions to prevent or reduce occurrence of medical errors. And the one important direction can be application of information technology. So we started around 2007 together with Greg Cooper, who actually is one of the students that Peter advised while he was bachelor at MIT. So Greg is a faculty at University of Pittsburgh. So we started this project about 2007, and when you look at alerting in healthcare, the typical approach that was there around 2000 and still is the dominant approach is to use expert-defined rules to raise alerts and basically pinpoint. This is a problem, right? The problem is this technology, expert-defined rules, and this is time-consuming to build, and it's very hard to also anticipate all situations that can go wrong and to detect them with expert-defined rules. So what we did in 2007 basically said, let's try to look at and how we can use the data to potentially detect and prevent medical errors. So what we did, the big idea of this project is that we have past patients in past electronic health records. So let's try to see what are the typical patterns of care, and then use these patterns of care trying to identify whether the current patient management actions differ significantly from these expected workflows. And these expected workflows, there is a trace of that. The patterns are in data. So let's use data to learn these patterns and detect deviations from these. So basically, our key assumption was that outliers, these unusual actions, if we detect them, they often may correspond to medical errors. And these occurrence of outliers can happen in different contexts. There can be different reasons. So if they are outliers, there is some chance they are medical errors. Obviously, there are concerns with it. Some errors may not be presented as outliers, and some outliers may not be equal to errors. But our main hypothesis that we studied during the number of years we were involved in this project is that outliers are equal to errors often enough that it justifies to alert when we justify to alert on them when we detect them. So this was the main hypothesis that we tried to study, and here is kind of basic idea of the approach. I don't want to dive into details. The approach is basically a two-stage approach. First, we try to learn the models of actions from data, and after we learn these models of actions, we use the models to detect action outliers for the current patient. So we had to develop the methodology to build the models and then to basically detect outliers in current patients. So here's kind of a high idea or vision we had at the beginning. So this is the stage one or model learning stage. We try to use machine learning models based on past data in EHR repositories to learn how to associate data in electronic health record with different actions. Compile these models, and then in stage two, do the monitoring with the help of these models, where we are going to alert on actions, okay, that are unusual for that current patient. Okay, so these can be things like action that is unexpected. So somebody prescribes medication that is not appropriate, or also on the other side, maybe somebody forgets to prescribe medication that is desirable or expected for that patient. So this is a big idea what we try to do. And we started the project in 2007. We went through multiple rounds of model refinement and evaluations. There's models were based on machine learning. We tried to do and develop various patient state representations. We ran evaluation studies in 2009, then later in 2014. Obviously, the basically data that we ran these evaluation studies on kept growing. We started with post-surgical cardiac patients in 2009. We had about 2,500 encounters. And then we moved to ICU data in 2014. We used 25,000 encounters. And the results of these studies suggested that we are on the right path, that indeed there is a promise of using machine learning models and outlier detection to potentially detect actions that are clinically important. So we had out of the studies true positive alert rates as evaluated by panels of clinicians that use a look at our alerts between 0.3 and 0.7. The other important thing about our evaluation study, we were able to design the methods in a way that you could control the threshold for true positive alert rates. So you were able to increase the T-pars, but you reduce the number of alerts. We are diluting a little bit the T-pars when we relax the alerts. So what it means is, if we wanted to alert only when we were really certain about things, we didn't raise alert in all instances, but we were right in many cases. So here's the results of the study from 2014. So we were running the alerts on 64 medication models, 22 lab models. And here I'm showing two curves. One blue one is basically estimate of the T-par based on the results, based on the answers of clinicians who were reviewing our cases. And the red one is actually, we were also evaluating the results based on actions that were indeed performed by clinicians without our input, but they were recorded in EHR because all our analyses were retrospective. Okay, so this, you can control the threshold, and we got T-pars pretty good. This is precision of the alert, about 0.7, and from 0.7 to 0.3. This is on medications. These were medication omissions. Essentially, we were saying you should prescribe this medication. The T-pars for the tightest thresholds were close to 0.7, and then it went down when you realize the threshold. So this was at the end of 2014 when we finished the study. And there we faced, obviously, these two things. We felt like the models are not there. We need to improve them. And the second open question was that in terms of our vision, you want to apply and do the alerting and detect medical errors on current patient, and current patient should be in real time. Okay, so I'm going to kind of focus. We build lots of new machine learning solutions in order to make this happen. That try to deal with time, that covered point processes or variety of non-parametric models built for representing events and actions in time. But here I'm trying to show you something that we built to make things work in real time. So before that, and actually still just said, when people try to analyze electronic health records data, you do the extractions online, you do all the data cleaning, abstraction, segmentations, featureization, model learning and application, everything is done offline on retrospective data. The challenge, obviously, is if you want to apply and make this technology work at the bedside, you need all these things need to happen in real time. So this was one of the big challenges we actually promised to do, and one of the aims of the NIH grant that we investigated is to actually see how we can get things done in real time. And this is kind of a result of this work. We built a framework that supports the real-time alerting, where you can fold a variety of machine learning for alerting. They can be predictive models, and you can do it and basically make it work in real time. So this platform we call NOMA AI platform is performing automatically data extractions from the production database, data cleaning, data preprocessing. It's doing the expansion of time series. So we not only take time series that are in electronic health records, we generate on-fly new time series. For example, abstractions, you can generate the whole hierarchies of medications and so forth. And basically the upper branch is model learning branch, where we have a database that basically covers the past patient data. Currently we have about 90,000 ICU encounters sitting there. We use the model training, okay, on those on the database. But what is important is these models can be now seamlessly folded into the real-time branch that essentially executes in real time on the production data. And it's performing model applications and generates alerts, and we actually run evaluation studies currently in real time. To give you an idea what we are doing, currently we do pools from 14 ICUs at UPMC that covers 120 to 140 patients. We do pools every 5 minutes. We have the data that are in the production database. We have alerts from them in 1.5 minutes. And we are applying this. Currently, we had about 77 alert models. We did some improvements in architecture. We can probably deploy now hundreds of machine learning models that will work in these minimal delays. So here is basically, we run evaluation study. We build our outlier-based alerting methods. We are trying to run them in real time. This is a dashboard that controls what we see. So you can, not sure whether it's visible, you can see the bedside. There is a FIN number. It's removed for privacy purposes. And then you have different medications that you are alerting on and different strengths of alerts. So we are running actually this system is running in real time. We've been running for about 1.5 years. I mean, we keep updating things, but it's in place and it's able to pump the data and do the machine learning applied in real time. Here's some preliminary results of the study from January, August. We have the alerts evaluated by clinicians. They are getting alerts in real time. There are these physicians, it's not full clinical study. We are feeding these alerts to clinicians that are not directly involved in care. They are ICU physicians, but not on duty at that time. And they are making assessments of these alerts. We have some estimates about the true positive alert rates that we estimate based on precision of our models, based on past data. And currently, from the study, it was covering periods of January, August, our estimates are just below the T-pars that we really achieve. So we know that actually our estimates are lower bounds, so this actually indicates that indeed the correctness of some of these alerts is in line with the estimate. This one issue is this framework. When we evaluate things in real time, we don't have continuously the physician sitting there and evaluating the alerts. They log in at certain periods of time, and that actually creates a little bit of problem because we don't see the strongest alerts, the ones that are more severe alerts, because they look at random times. And some of these alerts that occur, they are typically resolved. People notice them, and if you have, say, 2-hour gap, they are get noticed in meantime. So we have some strong alerts, but typically the precision of our alerts due to the workflow evaluation is a little bit lower. So in terms of, we are kind of excited about this. We got good results, initial results, and real-time workflows and real-time deployment of these alerts. We obviously still feel there is a room to improve the precision of the models and make the models stronger. But we also feel that we made one important step towards deployment of machine learning to bedside, and that is having a real-time framework that can deliver machine learning models and apply them and show the results to physicians. And we believe this is scalable to hundreds of models. So that's our work. Here I acknowledge some of the people working on the project. This project spent more than 10 years. So Greg Cooper, Joe Clermont, and 8 graduate students that actually I advised during these 10 years that participate in the project. Let me finish with the couple of pictures that are from Pete's website, but actually when I look at them, these are memories of, we had Medji retreats in Talbot House in Vermont, which was, one was 91, 97. It was fortunate to participate in both of them, and there also as a whole group attended these triple AI medicine workshops that were held in the 90s. And it was fantastic forum to communicate and speak to colleagues in AI medicine era. So all this is basically happened thanks to Pete support, Pete leadership, always having the best group of students and very collaborative and always critique, and he always had our back. I mean, he always supported us. Thank you, Peter.
We can take a couple of questions from Tia.
So, what was the metric that you were using for performance? 0.2 something? What was that? Was that precision?
So what we are trying to estimate is the precision of the alerts, but then we are evaluating against clinical reviewers. So if I raise an alert, we calculate true positive alert rate. Okay, so that basically says how many of the alerts turn out to be accepted and clinically useful. So we range between 0.7 to 0.3 on some range, reasonable range, and then also one important thing is that you can control these TPARs. The models are built in a way that the stronger alerts typically is determined by machine learning models